Hello dear friends, our talk today will be about the anatomy of the sacrum, sacral fractures and pathology. As you all know, the sacrum is almost the last segment with the coccyx of the vertebral column, and it's not common to have sacral fractures, but every now and then we see it, and it's very important to know the types and classification and how to deal with it. So, starting by the anatomy of the sacrum, as you all know, the sacrum is the last part and the coccyx the last part of the vertebral column, and it is uniting the two iliac bones together, forming the posterior wall of the pelvis and articulating with the iliac bone with one of the strongest joints in the body, which is the sacroiliac joint. The sacrum is like a shield at the base of the lumbar spine, very strong shield, formed by the fusion of 5 sacral vertebrae. And as you know, it looks like an inverted triangle with the base upwards. And it forms, of course, the posterior pelvic wall supporting the upper body weight. And it features 4 pairs of foramina, anterior and posterior, for the passage of the nerves and vessels. And it articulates with L5 lumbar vertebra superiorly and the coccyx inferiorly and the iliac bones laterally, forming the sacroiliac joint. So this is the anatomy of the sacrum. It is like a triangle. The base is up, articulating with L5 by the disc, which is a fibrous joint, and the inferior articular facet of L5, forming the lumbosacral articulation, and it is formed by the fusion of 5 vertebrae, 1, 2, 3, 4, and 5, and it carries 4 anterior foramina and 4 posterior foramina, and laterally there is the alum of the sacrum, which is a site for fusion when you do lumbosacral fusion, and also the sacral promontory, which is the anterior part and rostral part of the sacrum. Looking from behind, we will find that the sacrum has got also 4 foramina, and in the middle there is a crest called the median sacral crest. Lateral to it, between the median and the foramina, the intermediate sacral crest. Lateral to the foramina is the lateral sacral crest, and here the caudal part of the sacrum, you find non-fusion of lamina 4 and 5 sacrum, forming what we call the sacral hiatus. So, as we said, a base, superior surface, articulating with the sacral promontory, which is with the L5 and with the joint of L5S1. Also, the alum is like a wing projecting of S5 vertebrae, and as we said, could be the site of fixation. And the apex is the tip of the sacrum articulating with the coccyx. Of course, it has an anterior surface, smooth and concave, and a dorsal surface, rough and convex. So if we look to the sacrum from anterior, the anterior surface is smooth, it is concave, and as we said, the anatomy, you all just said it now, of the anterior sacrum and the anatomy of the posterior sacrum. Anterior sacrum, you find articulation through the disc with L5 and through the inferior articular facet of the L5 with the superior articular facet of the sacrum, forming the sacroiliac, the lumbosacral joint. And this is a coronal section of S1 through the sacrum. Also, the sacrum has a central canal, which is called a sacral canal, continuous with the central canal of the spinal cord rostrally. And this sacral canal carries, because it's a common question, sacral nerve roots, part of the coda equina, on their way to different parts of the pelvis. It carries a dural sac. As you all know, that the dura ends opposite S2 vertebra. So the canal contains dural sac ending at S2. After S2, there is a sacrococcygeal ligament, which is extradural, extending from S2 to the coccyx. And also it carries lateral and median sacral arteries. So the sacral canal, coda equina, dural sac ending at S2. After it ends, sacrococcygeal ligament, continuing with attached to the coccyx after that, and lateral and median sacral arteries. The sacral foramina, as we said, 4 pairs anterior, 4 pairs posterior for the exit of the anterior and posterior nerve roots. And there is an opening, we saw it now, which is the sacral hiatus, is a gap in the lower dorsal sacrum due to what? Non-fusion of the lamina of S4, S5. So if you imagine the sacral vertebrae are fused, they have lamina from behind. The lamina of S4 and S5 are missing, forming the sacral hiatus. What is the importance? It is the site of epidural injection in obstetrics and gynecology, and through it passes the S5 root, the coccygeal nerve roots, the filum terminal, as we said, on its way to the coccyx, and some fibrofatty tissue. And after that, we have the posterior sacral surface, as we said, has a median sacral crest, intermediate sacral crest, and lateral sacral crest, according to the relation with the foramina. So the midline, they are the median sacral crest. Between the midline and the foramina is the intermediate, and lateral to the foramina is the lateral. So again, median, intermediate, lateral, foramina here, hilum of the sacrum, central canal behind this, and the sacral canal, as we said, and here the sacral hiatus, and there is a horn on each side called the sacral cornua. And of course it is articulating with the coccyx, as we'll see. The anterior pelvic sacral surface, as we said, is smooth and concave. The anterior part of the upper surface is called sacral promontory, forming the posterior margin of the pelvic inlet. And of course we talked about the sacral foramina another time. 5 fused vertebrae, articulation with the L5, with the disc and the articular facets, alum, site for screw application in lumbosacral fusion, and the sacrococcygeal joint articulating the caudal sacrum with the upper part of the coccyx. Joints of the sacrum, most important of them is the sacroiliac joint, but there are other joints also, what we call the lumbosacral joint, as we said, between L5 and S1, disc space articulating fibrous joint, and the synovial joint between the sacrum, superior articular facet, and the inferior articular facet of L5. There is fibrous joint and synovial joint, And below we find the sacrococcygeal joint between the sacral apex and the base of the coccyx, and it's a thin, weak joint not bearing weight. And also the sacroiliac joint is a synovial joint, very big joint between the lateral surface of the sacrum and the iliac bone, iliac articulation. It acts as a shock absorber of the spine. It allows a small range of motion, just 3 degrees, and it transfers the weight from the spine to the hip joint on either side, protecting the hip joint, and it is a very common source of low back pain. So as we said, the sacrum articulates superiorly with the lumbosacral joint and inferiorly with the sacrococcygeal joint and laterally with the sacroiliac joint. And this is a picture of L5S1 and how is the sacroiliac joint superiorly with L5, inferiorly with the coccyx, laterally to iliac bone. This is anterior view of the sacroiliac joint, This is the posterior view, articulation of the sacrum, inferior articular facet of L5, superior articular facet of the sacrum, and the sacral canal, and the sacral foramina. And this is from posterior to show you how the weight of the body in the midline is distributed on either side to the iliac bone, to the hip joint, and to the femur, and so on. Another view showing the sacrococcygeal joint between the sacrum and the coccyx. Talking about the sacral ligaments, it's very easy. We talk about the interosseous sacroiliac ligament between the bone of the sacrum and between the bone of the iliac bone. It is one of the strongest ligaments of the body, preventing forward and downward movement of the body. If you don't have this joint, there would have been a slippage of the lumbar vertebrae and over the iliac bone. So it's very easy. At the bony level is the stronger joint, interosseous, between the osseous, the bone of the sacrum, and osseous, the bone of the iliac bone. And we have an anterior sacroiliac ligament in front of the sacroiliac joint, and posterior sacroiliac ligament giving stability, composed of short and long components, and the superior intracapsular ligament, which might be absent. It's not always present, and it's not very important. So the most important is the interosseous sacroiliac ligament, and less important or weaker is the posterior sacroiliac, but still strong. Posterior sacroiliac ligament. Weaker is the anterior sacroiliac ligament, and sometimes superior intracapsular ligament can be present or not. So if you look on a coronal section from above, and we see that this is the sacrum and this is the iliac bone, the joint here is the interosseous ligament, very strong ligament. Ventral to it, the ventral sacroiliac ligament, and dorsal to it is the dorsal sacroiliac ligament. So, interosseous, dorsal, ventral, and maybe the superior. This is to show you that the posterior sacroiliac ligament is a very important ligament extending from the sacrum to the iliac bone and having short and long components. So this is the posterior sacroiliac ligament. This is interosseous sacroiliac ligament. Interosseous sacroiliac ligament, posterior sacroiliac ligament, and you can find sometimes the superior, and of course anterior you find the anterior. Here is the anterior sacroiliac ligament. It's not of the importance of the posterior sacroiliac ligament. And here again you can find posteriorly the posterior sacroiliac ligament. So we have several important sacroiliac ligament posteriorly. We have the interosseous ligament, and we have the anterior sacroiliac ligament, and superior might be present or not. And also I want you to pay attention to accessory ligaments, one between the sacrum and the ischial spine called sacrospinous ligament, and one between the sacrum and the ischial tuberosity called sacrotuberous ligament. So in this view we can see the very strong sacroiliac interosseous ligament, the posterior sacroiliac ligament with short and long components. So this is the posterior sacroiliac ligament. Short components, long components. Of course we have the anterior sacroiliac not seen here. But remember this, between the sacrum, ischial tuberous, sacrotuberous, between the sacrum and the spine, sacrospinous ligament. And these are the accessory sacroiliac ligament. So we have a very important sacroiliac ligament between the sacrum and the iliac bone, and some accessory ligaments connecting the sacrum with the iliac bone. As we said, the sacrotuberous ligament between the sacrum and the ischial tuberosity, the sacrospinous ligament between the sacrum and the ischial spine, and there is iliolumbar ligament. It is not arising from the sacrum, but it is important in the stability of the joint. It is a strong ligament between the transverse process and the body of L5 and the iliac bone. So what we call the iliolumbar ligament between the body of L5, between the transverse process and the iliac bone. Of course, anteriorly there is the anterior longitudinal ligament, which is extending down to the coccyx. This is the promontory of the sacrum. This is L5. This is the anterior sacroiliac ligament. And this is the sacrospinous ligament. Of course, this is the sacrotuberous ligament. So as we said, sacrotuberous, sacrospinous, and iliolumbar. Again, we have posterior sacroiliac ligament, short components, long components, and the sacrospinous and the sacrotuberous. Above the sacrospinous is the greater sciatic foramen. Below it is the lesser sciatic foramen. You can revise the anatomy. Of course, the sciatic nerve, the piriform muscles, and many muscles are exiting from the pelvis to the thigh through the greater sciatic foramen. And also here you can find some ligaments between the sacrum and the coccyx, what we call the lateral sacrococcygeal ligament and the posterior sacrococcygeal ligament. Of course, if there is posterior, there is anterior sacrococcygeal ligament. And another view from the lateral side, the right side, obturator here, the sacrum, the sacrospinous ligament, the sacrotuberous ligament, the greater sciatic foramen, the lesser sciatic foramen. Of course, this is the central or the sacral canal, part of the central canal. The coccyx, what we call the tailbone, typically consists of 3 to 5 rudimentary vertebrae. So It can be 3, it can be 5 vertebrae, it can be 4. And the sacrococcygeal symphysis connects the coccyx to the sacrum, as we said, allowing some range of motion. While we are sitting, it bends a little anteriorly. In childbearing and defecation, it can allow some degree of motion of the coccyx. And as we said, the ligaments include anterior, posterior, and lateral sacrococcygeal ligaments and interarticular ligament. Applied anatomy, coccydynia is the name for severe pain from the coccyx, can be related to fracture of the coccyx or some displacement, strain, like during delivery. And most of the time, it is managed conservatively with painkillers and cushion. You can sit on it not to compress the coccyx, and the conservative treatment, the patient improves within 8 to 12 weeks. This is very important. He says, how long am I going to feel this pain? You should tell him between 8 to 12 weeks. And this is the posterior view, the sacrum, the lateral, as we said, posterior sacrococcygeal ligaments, and posterior sacrococcygeal ligament. There is a superficial and deep component, and of course, anteriorly there is anterior sacrococcygeal ligament. Muscles around the sacroiliac joint, back muscles, as you know, the multifidus or the erector spinae muscles, and the buttock muscles like the piriformis and gluteus maximus, and the hip muscles like the iliopsoas, especially the psoas muscle, and the thigh muscles, the hamstring muscles, is the biceps femoris. So, from behind, erector spinae and the gluteus maximus piriformis, and from the front, the psoas, and from behind also the biceps femoris. This is the multifidus or erector spinae, and this is the piriformis muscle, and this is, of course, here is the gluteus maximus, as we'll see. This is the gluteus maximus, this is the piriformis. They are all related to the piriformis coming out from the greater sciatic foramen, so it is very close to the sacrum. And of course, you have the other muscles closely related, the obturator internus, obturator externus with the two gemelli, and the quadratus femoris, deep, and the gluteus maximus, superficial. And this is an anterior view. You see that this is the iliacus, and this is the psoas, and the psoas is passing in front of the sacroiliac joint. And this is about the anatomy. Now we talk about the fractures. Sacral fractures account for 45% of pelvic fracture. If one has fractured pelvis, 45% will have some sacral involvement, and it may result from a high impact injury in young individuals and osteoporosis in adults. In adults or in old age, maybe a small trauma can cause fracture because of osteoporosis. And very important to know that most sacral fractures can be treated non-operatively unless it is unstable or displaced. You know, any fracture in the body needs a reduction or decompression and stabilization. Most of the sacral fractures, they do not need operative intervention, but they are treated conservatively. Sacral fractures represent an upgrowing collaboration between pelvic and spinal surgeons. As we said, pelvic injuries, 45% sacral injury. The pelvic injury is managed by a pelvic surgeon or an orthopedic surgeon, but the sacrum can be managed by a neurosurgeon. And treatment of the sacral fracture is based on what? Stability of the fracture. Is it mobile or stable? The presence of neurological symptoms. Can it cause coda equina, incontinence to urine or stools? And the general condition of the patient, if he has concomitant injuries and the risk of anesthesia. So you have to think about, is this fracture stable or not? Is it compressing, causing neurological deficit or not? Is the general condition of the patient good for anesthesia? Most sacral fractures, as we said, can be treated non-operatively if they are stable and non-displaced. And there are different classifications, like all other spinal classifications. There is a different classifications of sacral fractures exist. However, treatment is not standardized. We don't have an algorithm how to treat sacral fractures, but I will show you, and we can build our own plan. I will show you how to build it. So, classification of sacral fractures, very simple. We can classify them into vertical fractures. This is the core of Dennis classification. Transverse fractures, they are classified by Ruakami classification, the very famous Ruakami, the one who started the screws in the world, the rods and screws. And the AO classification, which is present in all parts of spinal injuries, and it is characterized by their impact on weight bearing and stability, as we'll see. So these are all the classifications: Dennis classification, Ruakami classification, AO, and there is Isler classification, many classifications. So let's start by the Dennis classification. It is describing vertical fractures of the sacrum, and zone 1 is a fracture involving the sacral and lateral, very lateral fracture, lateral to the neural foramina. Zone 2, fracture involving the neural foramina, but not the neural canal. Zone 3, fractures involving the spinal canal, medial to the neural foramina. So, starting from lateral to medial, lateral to the foramina, zone 1. Involving the neural foramina, zone 2. Medial to the foramina involving the canal is zone 3. And here is Dennis classification. Zone 1, lateral to the foramina. Zone 2, passing through the foramina. And zone 3, medial to the foramina into the spinal canal. Another zone 1, zone 2, zone 3. Very simple classification. And the Ruakami classification, as we said, you notice that Dennis is describing the vertical injuries. Ruakami is classifying the transverse fractures. So type 1, if it is undisplaced, it is fractured, transverse fracture but in place. Type 2, if it is angulated. Type 3, if it is completely displaced. And type 4, if it is impacted. So in Dennis classification, you look anteroposteriorly. In Ruakami classification, you look lateral. So it can be type 1, not displaced. Type 2, displaced. Type 3, completely displaced. So type 2 is partially displaced or angulated. The type 3, completely displaced, and type 4 is impacted fracture, like comminuted fracture of the upper sacrum, but in place. So in Dennis, looking anteroposterior. In Ruakami, looking lateral. Not displaced, angulated and partially displaced, totally displaced, impacted. Type 1, in place, angulated, partially displaced, totally displaced, impacted. The AO classification of sacral fractures, as you all know, all the AO classification we have morphology of the injury, which is very important, but it relies also on the neurological status and case-specific modifiers, as usual. So About the morphology, we have classified into type A, type B, and type C. Type A is lower sacrococcygeal fractures in the lower part of the sacrum, and it is not affecting stability, but they are further classified into A1, A2, and A3. Type B, unilateral longitudinal sacral fractures, and type C, unilateral vertical sacral instability involving L5S1 facet or bilateral or U-shape. We'll see it now. So when we talk about AO classification, A1, type A, A1, it is in the lower part of the sacrum, whether it is compression or avulsion traction. A2 is non-displaced transverse fracture below S1 joint with low incidence of coda, but A3 is displaced transverse fracture below S1 joint with high incidence of coda. So in A fractures, the sacrococcygeal joint, the sacroiliac joint is not affected, but if it is in the caudal part of the sacrum, is A1. If it is in the sacrum itself, but not displaced and below the joint, is A2. Also it is below the joint but displaced, is A3. So here A1, caudal part of the sacrum, not weight bearing, not very important, and A2, as we said, it is extending without displacement and below the sacroiliac joint. And here also A3 is below the sacroiliac joint but displaced. Avulsion, caudal part, below the joint, not displaced, and below the joint but displaced. A1, A2, A3. Type B is very simple. As we said, A was talking about transverse fractures. Type B is talking about vertical fractures. B1, if it is corresponding to Dennis zone 3, you remember it is injuring medial to the foramina in the spinal canal, and B2 corresponds to Dennis 1, which is lateral to the foramina, vertical, and B3 is Dennis zone 2 injury involving the foramina. So B1 like Dennis 3, B2 like Dennis 1, B3 like zone 2. So again, B1 medial to the foramina, which is zone 3, B2 in the foramina, which is lateral to the foramina, zone 1, and B3 involving the foramina, zone 2. So B1, as we said, vertical fracture lateral to the foramen. B2, vertical fractures medial to the foramina, and B3, vertical fracture involving the foramen. Very easy. A, we're talking about transverse. B, we're talking about vertical. And type C, it's not vertical or transverse, it's a combination of both. So CO, C0, it is U-shaped fracture, but non-displaced. C1 is unilateral type B fracture, but involving the sacroiliac joint. So whenever you have a U-shaped fracture, non-displaced, it is no longer vertical or transverse, this CO. But if you have unilateral B involving the sacroiliac joint, Remember, B was not involving the sacroiliac joint. This is C1. Bilateral B without a transverse component, but involving the sacroiliac joints, high risk neurological injury. And C3, displaced U-type fracture with a high likelihood neurological injury. So C1, C0 is non-displaced. C1, B-type fracture on one side involving the sacroiliac joint. C2 is bilateral B fracture, but without a transverse component, but it is non-displaced. C3 is displaced U-type. We'll see it. Type 0, non-displaced U-shaped fracture. It has a vertical and transverse component. Vertical shouldn't be just U like that. Here is a U, here is a U, here is a U. Type 1, unilateral B fracture involving the sacroiliac joint. You see, it is extending to the joint and there is fracture of the articular facet, fracture of the joint. So this is C1. It is like B involving the foramina, but the joint also. Joint involved, it becomes C1. C2, bilateral B-type fracture without a transverse component. We said about the B, we have a vertical component. So what about if we have two vertical components, 1B and 1B? In this case, it is considered a C, a C2. Here it is involving the foramina. Here it is lateral to the alum, lateral to the foramina. Whenever we have two vertical fractures without a transverse component, it becomes C2. Why C2? Because it has two. Again, C1, as we said, is involving the joint. C2, bilateral B. And C3, displaced U fracture. So it is a U, as we said. C0, there is a U. U means a vertical and transverse component, but on looking laterally, it is displaced. So it is C3. Again, C0, non-displaced U-shaped fracture. C1, unilateral B fracture involving the sacroiliac joint. So it's no longer B, it's C. Or, so it is involving the joint here. C2, bilateral B-type fracture without a transverse component. Shouldn't be involving the joints, but there is no transverse component. Type 3, displaced U fracture. When I say U, I have a transverse component, but it is displaced. Neurology, as you all know, all cases of AO classification cannot examine the patient NX. No neurological deficit is N0. Complete spinal cord injury is N4. In between, if it is a transient that recovers, it is N1. If it is nerve root injury, it is N2. If it is coda equina or incomplete cord injury, it is N3. It is a complete spinal cord injury is N4. So NX not examined. N0 normal. N4 complete cord injury. In between them, transient is N1. Nerve root N2, coda equina or incomplete cord N3. And the modifiers here, M1, you add it if it is severe soft tissue injury. M2 if the patient has metabolic bone disease like osteoporosis, like any other form of hyperparathyroidism. And M3 is anterior pelvic ring injury. If there is injury associated with the pelvis, it is more unstable. Not only the sacrum, but the pelvic ring, like the symphysis pubis, like the ischium, is injured also, is M3. And if the joint, the strong joint of the body, is injured, it is M4. These are the modifiers. So, as I said, I cannot do an algorithm strong, but we can have some hints what to do. When surgery is indicated, when is it indicated in fracture sacrum? As we said, when there is compression and neurological deficit, you decompress the neural elements, and reduction, bringing the pelvis and the sacrum into a radiological alignment, and or provide fixation and promote early mobility and healing. So, how to formulate a surgical plan? You ask yourself several questions. Is neurological decompression needed in case of symptomatic neural compression? And how will the fracture be reduced, open or closed? Because it is superficial, the sacrum, so you can reduce it closed. Is lumbosacral fusion required? Is there injury of the sacroiliac joint or the transverse process of L5 needing fusion? And what instrumentation is best suited, whether it is open or closed? And is fixation of the anterior limb required? Do I need pelvic fixation in addition to the sacral fixation? And will this fixation allow to early weight bearing? Why do I do fixation? To allow the patient to be ambulant. Would this fixation help the patient to be ambulant? And last but not least, the optimal timing for surgery. Concerning the general condition associated injuries, should we operate immediately or we should wait until the general condition stabilizes and we deal with other more serious injuries? Thank you very much for your attention, and I hope we meet soon in another, it's about to finish the series now of applied neuroanatomy. Maybe we have 2 more subjects to talk about, and I thank you very much for your attention, and till we meet soon, be safe and have a good time.